Hello, and welcome to the Chest Critical Care Podcast, where we host a discussion with the authors of important articles from the journal, adding context and commentary to the challenges facing clinicians in the field of critical care medicine. To introduce today's topic, here's your host, Dr. Gretchen, Sacha.
Hello, everybody, and welcome to the Chest Critical Care Podcast. My name is Gretchen Sacha. I'm a critical care pharmacist at the Cleveland Clinic and an associate editor for Chest Critical Care. Today, I am very excited to discuss two complementary studies that were recently published in Chest Critical Care, and they examine an important but often under-recognized issue in early airway management, and that's the sedation gap that can occur after neuromuscular blockade during rapid sequence intubation or other bedside procedures. Now, both of these studies that we're going to discuss today explore how often patients may experience inadequate sedation while still paralyzed and evaluate potential strategies that can reduce this risk. Now, to help us explore this topic, I'm joined by the first authors of both studies. Dr. Isabel Mangaoang, whose paper, Mind the Gap, Estimated Duration of Inadequate Sedation After Rapid Sequence Induction and Intubation in Critically Ill Patients. This study examines and characterizes the problems that we are facing and focusing on today, and that is awareness during paralysis. Now, by specifically describing the prevalence and duration of sedation gaps in critically ill patients that are undergoing procedural paralysis. Now, Dr. Mangaoang is a critical care pharmacist at Sutter Health in Modesto, California. And our second guest today is Dr. Stephanie Lee, whose study Bridge the Gap, Effective Clinical Support Tool on Inadequate Sedation After Procedural Paralysis, attempts to test a solution to the problem of awareness during paralysis by evaluating the impact of a clinical decision support tool and education on reducing sedation gaps after neuromuscular blockade. Dr. Lee is a senior critical care pharmacist at UC Davis Health in California. Thank you both for joining the podcast today.
Hi, Dr. Sacha. Thank you for the kind introduction and having us here today at the podcast. And I'm happy to be part of the podcast series.
Yeah, thank you so much. It's really great to be here from my end as well. I've been listening to clinical podcasts since pharmacy school, so it's pretty surreal to now be a part of one.
That's great. We're so happy to have you here. And I know we have a lot to get through and we have a relatively short amount of time to do that. So let's start and provide some context for our listeners. Now, both of these studies tackle what I would describe as a potentially frightening scenario for patients, and that's experiencing paralysis without adequate sedation. Now, Dr. Lee, could you briefly explain what is meant by a sedation gap and why this phenomenon is clinically important for critically ill patients undergoing rapid sequence intubation or other procedures?
Yeah, of course. And a sedation gap refers to the period of time when a patient is inadequately sedated but still paralyzed after receiving a neuromuscular blocking agent such as rocuronium. And clinically, this is concerning because the patient may be awake but unable to move or communicate. And that can lead to distress, pain, and awareness with paralysis, which may be associated with long-term psychological effects such as PTSD as well. And the issue often stems from the fact that a non-depolarizing neuromuscular blocking agent such as rocuronium and has a longer duration than the induction sedatives that are used.
Now, Dr. Mangaoang, your study focuses on characterizing this problem. So what initially motivated your team to investigate sedation gaps after procedural paralysis?
Our inspiration for this actually stemmed from several cases that we had reported involving patients who experienced prolonged paralysis after receiving just a single dose of rocuronium following this bedside procedure. And in some of these situations, sedation was actually stopped because of the misconception that the patient wasn't waking because of oversedation. When that didn't work, Sagamodex was administered and the patient immediately became responsive. What's concerning is that because sedation was held, these patients likely experienced awareness with paralysis. And importantly, I think it's not unique to any one institution. In my current practice, which is a different hospital, I've actually seen similar situations. And even as recently as last year, a patient reported awareness during a procedure immediately that occurred after intubation because of this delay in subsequent sedation. So given that more than 650,000 intubations occur outside of the OR every year, it really made us wonder how often this might be happening but going unrecognized. So eventually that led us to investigate sedation gaps as a practical way to try and describe when patients may be at risk for awareness with paralysis after just a single dose of procedural rocuronium.
Yeah, it's fascinating and truly, honestly, frightening at times, and to see how prevalent it really is and how it affects so many of our patients. Now, going back to you, Dr. Lee, your study evaluates a clinical decision support tool that's designed to address this issue. So before we get into the details of the intervention, can you briefly describe what prompted the development of this strategy at your institution?
Yeah, so we also noticed several recurring issues such as the delay in starting sedation, inconsistent dosing practice, and inadequate communication when patients are transferred between services. And there also wasn't a dedicated clinician to ensure sedation was addressed during these bedside procedure, such as rapid sequence intubation. So we had conducted a failure mode analysis and to identify the root cause. And one key insight that we gained was that education alone wasn't enough. So we switch focus to build upon a system level solution, and which came to the development of our strategy.
That's great. I'm really looking forward to picking that apart and talking more about it. So let's dive deeper into these studies and help the listeners better understand how sedation gaps were measured and then what the investigators found. So first, we'll focus on Dr. Mangaoang, your study, which is titled "Mind the Gap," to give the short title of it. So can you briefly walk us through the overall study design and the patient population that you included?
Yeah, it was a retrospective cross-sectional study at one large academic medical center with 5 adult ICUs. We included all hospitalized adult patients who received rocuronium for a bedside procedure, but we excluded them if peri-procedure they're already receiving continuous sedation, had any additional paralytic doses, or were pericardiac arrest. And the primary outcome was the sedation gap.
Now, I think that one of the more interesting aspects of your study is how you defined and measured the sedation gap. So can you explain how your team determined when a patient was considered adequately sedated after receiving a neuromuscular blocking agent?
I think this is a very good and really important question, actually, because it's central to how we calculated the sedation gap. We defined adequate post-induction sedation as doses of midazolam 2 milligrams or more every 15 minutes, propofol continuous infusions 20 milligrams per kg per minute, or ketamine continuous infusions of greater than 10 mg per kg per minute. Notably, Precedex was not considered to be adequate sedation. All that being said, there really was no clear guidance for sedation dosing in this specific setting, because in reality, sedation requirements, their onset, peak duration of any of the agents are very highly variable in these critically ill patients. Because of that, we intentionally chose more conservative dosing thresholds in order to avoid overestimating the sedation gap unintentionally. But really, in practice, something like propofol of 20 mg per kg per minute could reflect a starting point, but it might not be efficient or sufficient to achieve even a light sedation goal in some patients. So overall, the sedation dosing defined were really intended to model the sedation gap based on practice patterns.
I think this makes a lot of sense, and it is very nuanced, as we know as pharmacists, and tricky to really truly determine what the right doses would be to utilize in this kind of study. But I think everything that you did makes a ton of sense. So now let's talk a little bit about what you found. So what was the overall prevalence of sedation gaps in your cohort, and were you surprised by these findings?
We found that 85%, I'm going to repeat that for emphasis, 85%, just because it is a good number of patients experience a sedation gap of any duration during the presumed 60-minute period of paralysis. And the median sedation gap was 19 minutes. There's a lot more findings I could dive into, but I'll pause before I ramble on forever about the other interesting things that were there. But in terms of whether or not I was surprised, yes and no is the simple answer, but it's because being a clinical pharmacist at bedside, this is something we can commonly see and actively try to mitigate by going to the bedside and prioritizing that. But what was striking, I think, was just the magnitude and consistency of these sedation gaps. The cases we recognize or get formally reported are just a small fraction, really, of what's actually occurring in practice.
I agree with the emphasis, 85%. That is really eye-opening. And to go along with that as well, you reported a median sedation gap duration of nearly 20 minutes, which doesn't seem long, but is long. So from a clinical perspective, how should we interpret that duration in terms of potential patient experience or risk?
I think this is an important question because a key point to remember is that sedation gap really is a surrogate. It represents the period during which a patient may be at risk for awareness with paralysis, but it doesn't confirm the findings that awareness and subsequent psychological sequelae actually occurred. But that would require a lot more assessment and being able to interview patients after they're no longer sedated or delirious, which tends to not be as practical. But prior studies have shown that awareness with paralysis does indeed occur in this setting at rates around 1.9 to 3.4%. But let's just remember how common this procedure actually is. So with that in mind, a median gap of nearly 20 minutes does become clinically meaningful as it represents a non-trivial and preventable window of risk. And from a practical standpoint, sedation gaps are a very useful way to identify where processes might be falling short so that we can address them and improve patient safety and experience. And honestly, if I can speak a little less formally, I'm not sure if you or Dr. Lee have, or any of the listeners have ever experienced sleep paralysis, but it's absolutely terrifying even for a few minutes. So I imagine this is nothing compared to what some of our patients might experience in a medically induced paralyzed state in a hospital surrounded by strangers with things being done to them.
I completely agree. I think that perspective is really important because, again, it can be a truly frightening thing, and that is including all of the other things that are going on with the patients at the exact same time in the ICU setting and in the hospital setting. Now, tell us a little bit more about one of the other findings within the study. So as a pharmacist, I was particularly interested in the difference that was observed when a pharmacist was present at the bedside. And you talked a little bit about this, but can you walk us through those results and what you think may be driving that association?
Of course, I'd love to. As a pharmacist ourselves in this whole group, actually, we've actually found that there was no significant difference in the frequency with which patients experienced a sedation gap when a pharmacist was there or not. But when a pharmacist was there, the probability that the patient was initiated on adequate sedation was higher at every time point beyond the first 3 minutes following the induction period. Furthermore, the duration of sedation gaps significantly decreased with a pharmacist from a median of 40 minutes to 11 minutes. So these findings really highlight the positive impact clinical pharmacists could have on reducing awake paralysis. I think the association may really be because we're able to facilitate the entire medication use process, including order entry, preparation and delivery, safe administration, and monitoring. And other clinicians, of course, are capable of supporting this workflow, but our presence really helps distribute these responsibilities more effectively so that other team members can focus on other critical procedural roles, especially because there's a lot of competing responsibilities in this emergent setting.
I completely agree. It's really that it really kind of emphasizes that multi-professional and multidisciplinary need for caring for our patients and how our emphasis can be on one particular piece while the providers are on another very equally important piece. So thank you for expanding upon that. And now to talk a little bit more about how you apply and what we can take from the results of your study, again, shortly titled Mind the Gap. So for clinicians listening to this podcast, what are some of the practical steps that they can take today to reduce the risk of a sedation gap during rapid sequence intubation or procedural paralysis?
I think that this would really require a multifaceted approach across basically all stages of the medication use process. From a prescribing standpoint, if we consider using succinylcholine instead of rocuronium when succinylcholine is not contraindicated, its duration matches much more closely to that of induction agents. So we have to worry less about having awareness with paralysis. We could also optimize agent dosing, both to avoid unnecessarily prolonging paralysis and also ensuring adequate sedation. Post-intubation sedative choices and dosing strategies can also make a difference. And then on the operational side, making sure that we're minimizing delays in starting post-intubation sedation is very critical, whether that be by improving medication and supply access, streamlining workflows, or ensuring appropriate personnel. But finally, standardizing practices for monitoring paralytic recovery and improving handoffs should also be considered, especially to help ensure that ongoing sedation or reversal needs are recognized and addressed very promptly. So overall, it's likely going to take a combination of strategies rather than any single intervention.
Thank you. That's extremely helpful, and I think can really be some actionable things that we can all take back to our institution to see if we can can address this issue as well. And now, unfortunately, I'm going to pivot to our next study. I would love to keep talking about it more, but we do have 2 great articles to discuss today. So now, after your group identified how common sedation gaps were in that first study, it was then moved towards evaluating a potential solution. So Dr. Lee, this leads us into your study that's shortly titled Bridge the Gap. So now your study was set up as a pre-post study comparing clinical outcomes before and after the implementation of a clinical decision support tool that was combined with education. Now, can you tell us what patients were evaluated? Who did you look at? And then what was this tool briefly that was implemented?
Yeah, the patient population that was included in the Bridge the Gap study were similar to the Mind the Gap study as well. We included critically ill adults, and then both studies have patients about average age around 60 years old, and they were mostly male, and then primarily undergoing RSI in the ED or ICU setting. And our intervention centered around workflow optimization and involved a passive clinical decision support tool or CDS. And we embedded the CDS tool directly into the ICU airway order set and also into our order panels for all of our non-depolarization neuromuscular blocking agent orders. And the CDS tool linked paralytic orders with sedative orders and required clinicians to either order sedation at the same time or confirm that the patient was already adequately sedated before proceeding to ordering the paralytic agents.
Thank you. That is extremely helpful. And I want to pivot then to tell us about what your study actually found. So again, we're talking about Bridge the Gap. So can you tell us briefly what your study found? What was the median reduction in sedation gap? It was quite substantial. Can you tell us a little bit about that? And were these in line with what you expected, or were you surprised by the findings of your study?
Yeah, so the result of our study was significant, and then the median sedation gap we found decreased from a total of 19.5 minutes to 3 minutes, and within that 60 minutes window after administration of rocuronium. And we also saw fewer patients experiencing any sedation gap overall. And I think we definitely expected some improvement after implementation of the CDS tool, but we didn't exactly know how significant the sedation gap would decrease. And then I would say that the magnitude was larger than what we anticipated. And it really highlights how powerful a system level changes could be.
Yeah, I completely agree. I mean, it was I would say a relatively large reduction in that sedation gap, which I think is really great with the tool that you guys implemented. You also looked at and evaluated the probability of achieving adequate sedation over time. So can you help interpret that finding for our listeners and what it tells us about the intervention's effectiveness?
Yeah, so the patient in our intervention group were nearly twice as likely to receive adequate sedation at any given time. And then the time to sedation dropped from about 6.5 minutes prior to intervention to 2 minutes after, and which shows improved timeliness and consistency of adequate sedation post paralysis agent administration.
That's amazing. That's so great. So now I think one of the things that at least I, as a listener, and probably the rest of our listeners are interested in is how can we do something like this at our own institution? So what were some of the biggest challenges that your team faced when integrating this tool into the clinical workflow?
Yeah, I think that is a great question. And I definitely felt like it is feasible to implement it in other institutions as well. And then there were a few challenges that we saw, such as getting everybody on the same page and obtaining the buy-in from a multidisciplinary standpoint, and making sure that intervention would not slow down the urgent need of procedures. And that we were trying to implement the optimization without slowing down the process.
I think that makes a lot of sense. And now for institutions that may not have access to more advanced clinical decision tools or the resources that you guys had when you built this passive tool in your system, are there simpler strategies that could still help reduce sedation gaps at the bedside?
Yeah, I think there are definitely other options, and without having an advanced CDS tool embedded, that there are ways such as standardized protocols, having a checklist, or having a pharmacist or other clinician involvement, a dedicated person to think about sedation during these procedures, and also definitely in education as well. And as we saw in the previous Mind the Gap study, that having a pharmacist present has shown to reduce such sedation gaps, so that I felt like it could be implemented in an institution that's without advanced CDS tools.
Yeah, I completely agree. Thank you for that. That's super helpful. And hopefully we can all take something back to our own institutions about this potential issue. Now, since we've now talked about and seen both the scope of the project, the problem itself, and then the impact of a targeted intervention, Dr. Lee, how do you think these findings should change clinical practice moving forward?
I think the biggest impact is that both of our studies raise the awareness of something that often isn't obvious in real time. And the concept of sedation gap may not be intuitive. And it's easy to assume that giving an induction agent is enough of a sedation for these patients, but our data has shown that that's not always the case. And the first step for any institution is really to look at their own practice and to understand where delays may be happening and where the gaps may lie in their own workflow. And more importantly, our findings reinforces the key concept that sedation is just as critical as paralysis during these bedside procedures, and that it should be addressed timely.
Dr. Mangaoang, any additional thoughts?
Yeah, I definitely agree with what Dr. Lee said. And implementation of similar internal examination strategies, of sedation practices, as well as interventions should definitely be considered. I also hope that these studies simply bring further awareness of sedation gaps and the risks that they may entail, and spark more discussion on mitigation strategies so that we can hear more from the broader community.
I couldn't agree more. Now that we've talked about both Mind the Gap and Bridge the Gap, I want to talk about the future for this clinical question and for the both of you. So looking ahead, Dr. Lee, what are the next steps for your research group? Are there plans for prospective validation or even broader implementation of this evaluation and intervention?
Yeah, we're definitely very interested in conducting prospective validation and expanding this approach across other institutions as well, and as a collaborative research project to see how well it generalizes in different settings in different institutions. And also another area that we're excited about is to collaborate with our pediatric ICU colleagues to understand how sedation gaps affect our pediatric populations as well.
I think a pediatric evaluation would be of utmost importance as well. And I think even just larger evaluations of the epidemiological risk of this would be something that would be very interesting for the critical care communities, is really on large scales. How often is this happening? Because I think it's very eye-opening and happening more than we think. Now, Dr. Mangaoang, both studies highlight an important patient safety concern. Do you see future work focusing on patient-centered outcomes, such as awareness with paralysis or even psychological sequelae?
Yeah, I think this is definitely an important direction for future work, because if we can establish a clear relationship between sedation gaps and downstream clinical outcomes, it would really significantly strengthen the clinical relevance of this work and make it a lot easier for other people to be able to evaluate how they can better serve our patients. And ultimately, it would help move this from an observed safety concern to a really more actionable and universally prioritized quality target.
Yeah, I completely agree. I think that overall we definitely need a lot more in this area now that it's being brought to light more widely. Now, I'm curious, and I'll let either of you guys answer this. Are there additional factors such as sedation choice, dosing strategies, or timing that you think warrant further investigation on this topic?
Yes, I believe factors such as the optimal sedation choices and dosing frequency as well, and taking consideration of duration of the agent that were selected, and then even the role of different paralytic agents would warrant further investigation to find the most optimal combination of medications.
I think so too. And then even in the aspect of monitoring, it could be important because things like train of 4 and ratios are very useful to assess neuromuscular recovery after a paralytic. But in a one-time setting in a setting of a one-time rocuronium dose, the peripheral nerve stimulators can be difficult logistically and also has technical limitations at bedside. But there might still be value in being able to target a potential patient population in which we use monitoring to help guide our decisions around additional sedation or potential reversal. I think it would also be important to better define physiologic and patient-specific factors that might predispose individuals to prolonged paralysis, so that in that way we can target a higher risk population that would allow us to proactively tailor our sedation strategies to help reduce these gaps in these high-risk patients.
Yeah, it sounds like there's definitely a lot of need and a lot of areas that can be targeted for future research. And I hope and look forward to seeing some of that from you guys in the future. Now, to close us out, across both of your studies, what is the most important message that you want clinicians to take away? And are there any final insights that you would like to share with our listeners? Dr. Lee, would you like to begin?
Sure. So taken together, I think both of our studies show that sedation gaps aren't rare. They're common, measurable, and significant as well. And but the encouraged part is that they're also highly modifiable and with a patient-centered solution that's tailored to each of our institution as well. And for our clinicians listening, I think the key takeaway is really to look critically at your own workflow and at your own institution, and to identify where are the delays and where are the gaps and where can sedation be optimized as well. And the small gaps in the process can translate into real harm for our patients and has long-term psychological and physical sequelae. But these are exactly the problem that we can start fixing today.
Dr. Mangaoang, anything on your end? What are your thoughts?
I think Steffi really wrapped it up very well. And overall, I also hope these studies, again, help spark continued discussion within our community, since I think there's still a lot to learn here, and ongoing dialogue will be key in order to advance practice in this area.
I couldn't agree more. And I want to thank you both for being here with us, for talking about your studies, Mind the Gap, as well as Bridge the Gap. I love that they were both published around the same time in Chest Critical Care. So thank you guys both for being with us today.
Thank you. This was great.
Yeah, thank you for having us.
Of course. So I want to thank the audience and everyone for listening today and encourage you to read both studies. They're both available right now on chestcc.org. And the studies that we talked about are Mind the Gap, estimated duration of inadequate sedation after rapid sequence induction and intubation in critically ill patients, as well as Bridge the Gap, effect of a clinical decision support tool on inadequate sedation after procedural paralysis. And I want to thank our authors and speakers today, Dr. Mangaoang, as well as Dr. Lee, for talking with us about these two articles. Thank you, everyone.